Hi, I'm Dr. Ann Lowry, and this morning we'll be talking with Dr. David Beck, who's the Professor and Chair of Surgery Emeritus at the ASCRS Clinic. Hi.
Good morning.
What got you interested in colorectal surgery?
It started back, I went to the Air Force Academy, planning to be a fighter pilot. Had to pick a major, and the one that was close to my interest was life science pre-med. So I said, well, okay, I'll be a doctor. It was pretty obvious I wanted to be a surgeon. And their program was pretty extensive. We got to do a lot of animal surgery and stuff. So I went to medical school knowing I was going to be a surgeon, which obviously made my medicine rotations interesting. When I first got there, Frank Harford was the chief resident who was in the military, in the Air Force, so he was my liaison person. After a couple of days, I found him, kind of being on trauma call for 2 days, usual nose days, beard, tired, says hi, call me if you need me, and I didn't see him again for years. I did my residency in the Air Force, and Frank Harford was then the senior colorectal surgeon there. When I was an intern, Vic Fazio came as visiting professor. We did 3 proctocolectomies and cotangectomies in one day. It was very interesting. And then subsequently, Frank became chairman, was kind of my mentor. As a second year, I was the senior resident, got sick, so I was running the colorectal service as a second year, doing all the colectomies, so that was kind of great. And then it was very obvious, in the Air Force, if you did a fellowship, you went to a medical center. If you were a general surgeon, you got sent to Turkey, the Philippines, the Azores, somewhere not pleasant. So the only specialty I really was interested in was colorectal because it was endoscopy, good cases, and so ended up going to Cleveland. So then Vic was kind of mentor there.
So talk a little bit about what being in the service and interfacing with colorectal surgery, how that might be different than those of us who are not.
One advantage of the military is you get a lot of opportunities early. So I finished my fellowship at Cleveland Clinic, went back to the Air Force Hospital in San Antonio, and the next day I was the chief of colorectal surgery for the Air Force. So, okay. And because I had some mentors and networked with some people, I got opportunities to do things, write some books, travel, educate. At that time, the Air Force was not really involved in a war, so we had a lot of academic opportunities to do things. And so after being 2 years, I was chairman of the department. I said the Air Force, they kind of advance you quickly. And then Rick Roth came on as one of my junior partners, and so we did a lot of colorectal surgery.
And what was involved in the decision to leave the military and become the civilian?
The Air Force was changing a bit. They were more interested in people moving around and doing Air Force things and academic things. There was an opening at ASCRS Clinic, and so Byron Gathright kind of brought me on. I think he felt that I had potential to be chairman eventually, so actually a couple years later I was chairman at ASCRS. So I like the clinic practice. You get to see patients, do academic stuff, and it just worked out well with my personality.
So then how did you get involved with ASCRS?
Initially I did some research and wanted to present papers. If you want to contribute to our specialty, the society is one of the main ways to do that. There's a lot of opportunities to be on committees, do research, present papers, write textbooks, and just contribute in a lot of ways. And the society was my vehicle to do that.
And what was the path to leadership? Presumably not quite as fast.
Not quite as fast. I basically, you pass your boards, you become a fellow of the society. I was got to do that a little quicker because in the Air Force you do your residency. I was a surgeon for a year, and then went to fellowship. So I was a member in those days. You didn't have quite the candidate status, but I was a member for a couple of years and got to be a fellow sooner. Interestingly, when I did some research to go lightly, and so I was before my fellowship, I wrote Stan a note and said, "Hey, I did this research. Can I come to your meeting and present?" And he said yes. And then a year later, I was a fellow, and so I went to Vic and said, "Vic, I got to go give a talk at Stan's course," and he was kind of like gassed, like, "Excuse me." Anyway, so I gave a talk at Stan's course. There's a drive to be successful, and so you look for opportunities. The society gives you opportunities, and if you can do it, say yes, and accomplish it, you get more opportunities. So I was eventually chairman, I think, of the PR committee. And then a little bit later in my career, Bruce Wolf started the ASCRS textbook. And I was kind of brought on a little bit after the contract was written because it wasn't progressing quite as well. And so with my skill set of organizational things and nagging people. We got the first edition done, the second edition, so I think that really helped a lot.
And what do you feel like was your greatest accomplishment within the society?
I think some of the research we did with biopreps and some other the clinical studies and probably the textbook. We initially set it up so that the 2 senior authors would rotate off after a couple years. We were very interested in it being a society textbook and not, Dave Beck or Jim Fleshman or, Scott Steele's book. And so we've continued that, and I think Scott's taken over for the 3rd edition and the 4th edition, and he'll rotate off, and we'll get somebody young and interested to kind of fill his position down the road.
Well, it certainly has become the leading colorectal surgery textbook. So.
Yeah, I mean, it's multi-authored. There's some really good aspects to it, always room for improvement.
So when you were the president of the society, what do you think were the biggest challenges facing the society then?
Some of them have continued. The financial aspects, the society is in good shape financially, but some of our resource streams come from industry. And we always have this ongoing concern, how close we get to industry, how not to industry, other sources of income. And so I think that was some of the component. I don't think we had any big controversy the year I was president, so things ran pretty smoothly. We tried to reorganize things a bit. So I think the yearly financial concerns are probably what everybody deals with the most.
And did you come to your year as a president with one thing you wanted to accomplish, or mostly wanted to rise to the challenges? Or?
I think I followed Jim Fleshman. I think then Steve Wexner followed me, and so we kind of got together and agreed that we would. It's hard for a year to do any big project, and so we kind of set the tone of the president-elect, the president, and the past president kind of getting together, discussing issues, and trying to keep things moving along. Mostly just to kind of carry on the stewardship of the society and try and make it better.
So, what would you say is the biggest challenge from when you started training? Challenge to the specialty from when you started training to what you see now?
I think it's harder to practice. Electronic medical records is good things and bad things. Some things make it very efficient, some things make it very hard. I think we all spend a lot of time doing stuff that doesn't really involve direct patient care. I think that's challenging. Certainly we all hear the good old times when, the clinic needed more money, we just raise our charges and we'd have more money, and so that's different. A lot of external forces. And I think we're facing a critical nursing shortage. It's almost a daily problem that certainly in Louisiana we have trouble probably enough income to get the good nurses we need. And so we're having to do innovative things such as like team nursing. A lot of people want to work, 4 10-hour shifts instead of 5 days a week. So in the old days, I had my own nurse. Now I have a team of nurses, and so it's just some differences there.
And what would you say is the biggest challenge facing the society right now?
Somewhat, we have a lot of good young people, keeping them interested, the society provides them value. I mean, they have opportunities. Certainly at the meeting, I think networking is critically important to meet people, share experiences. And at least our generation, I don't think that does well on social media. Now, it may change in the future, but I think there's value of getting together, talking to people. We have quality people, getting some expertise, getting some mentoring, guidance, and all those things work together.
If you were looking into the future of what you think things will be different for the specialty in 10 years, what's your prediction?
Well, in some ways we're lucky that there are a couple things that we do that no one else wants to do. Some other specialties are competing. Really no one likes the anus and rectum, and no one likes stomas. So I mean, we do compete with GI for endoscopy. In those 2 other areas, we pretty much are the people that do it. And even though there are changes in the management of disease, such as anal cancer, really not a surgical disease anymore, but we kind of are the captains of the ship and monitor the patients and guide their therapy. So I think there's things we do. As a group, I think we're pretty open to change, making things better and adapting to it. So I think the specialty is on solid footing.
What advice would you give young people as they're starting their career?
I'd say spend some time reflecting on what your goals are, okay? And everybody has different goals. I mean, certainly family is important. Make some time for that. Decide what kind of practice you want and what you enjoy. I mean, I think if you go to work every day hating it, that's not a way to live. So I think figure out what's important to you and then either figure it out or ask people, how do you get where you want to go? And then basically, you know, fill the squares.
Who would you say were your most important mentors? And then the second is, how do those young people find somebody to ask?
Okay, I think Frank Harford initially was a mentor to me. Vic Fazio had a lot of contributions. Byron Gathright, when he came to Oxford, had a lot of contributions. And then there's a whole generation of people just above me who are very open. You know, you can go to Ira Codner, you can go to Stan, you can go to all these guys and just say, hey, you know, what do you think about this? And then my colleagues, Pat Roberts, Steve Wexner, we get together and discuss issues and you get advice. As far as the junior people, if you're fortunate to be in an institution that's good size and you have senior people, they're usually very good mentors. If you're not, just walk up to somebody and say, hey, I'm so-and-so, you know, can you give me some advice? And what's great about our specialty is everybody's approachable. We like each other, we want to help people, and so I'm happy to, you know, give people opportunities to write, do things, you know, give them advice, and so basically just identify one or two people that you think will help you.
What do you think is the future for training in colorectal surgery?
I think the 4-2 model may be coming. I have mixed questions about it. I mean, it's nice right now when you have a chief resident in your service, and if he says Mrs. Jones is sick, Mrs. Jones is sick. If he says, I think Mr. Smith's got to go to the OR, you say, okay, I'll meet you there. If the third year's covering and he calls you, and then you start asking some questions, you know, what's the temperature, what's the vital signs, so you need to come in and look at this patient. So, and then we'll have to spend more time teaching people how to do that aspect of it, as opposed to just the technical and the management skills of colorectal surgery. So I think it's going to make us a little different management training.
Do you think there's an upside to having 2 years, having the colorectal people with us for 2 years?
Yes and no. I think you might be able to do some more longer-term research projects as opposed to being there for a year, then kind of going on doing things. There seems to be a trend for us doing more than we used to. I mean, sometimes electronic medical record, sometimes it's just there's so much commitment on the resident's part, so I found myself doing H&Ps on the computer, you know, putting in orders, scheduling cases where it used to be the resident doing it.
So thank you for your time. It's really been a pleasure to hear your journey through colorectal surgery.
It's been a pleasure talking to you, Ann.